Hello everyone and a warm welcome to you all. Assalamu alaikum and good evening everyone. I am Dr. Shiraz Ali and today I have the privilege of presenting a comprehensive overview of ureteric stone covering their classification, grading, medical and surgical management, and long-term follow-up. Ureteric stone or ureteral folliculi represent one of the most painful and common urological conditions in clinical practice. They account for a significant proportion of emergency urology presentation worldwide, and their incidence continue to rise. This presentation is evidence-based and draws primarily from two authoritative sources: the Campbell Urology and EAU guidelines. I hope this talk will be both clinically relevant and practically useful, whether you are dealing with these patients in the emergency department, outpatient clinic, or operating theaters. Let us begin. Before we dive into detail, let me give you a brief roadmap of what we will cover today. We will start with epidemiology and etiology, understanding how common this condition is and who is at risk. Then we will then move on to anatomy and stone formation, particularly focusing on the natural nerving points and the ureter where stones tend to get stuck. The third section covers classification and grading, how we categorize stones based on size, location, composition, and the degree of obstruction they causes. And fourth, we look at the clinical presentation and diagnosis, how patients present, and what investigation are needed with particular focus on imaging. Fifth and sixth, the management section, we will cover both conservative and medical management, including medical expulsive therapy, followed by a range of surgical options available. Finally, we will discuss follow-up and recurrence prevention, a critically important but often overlooked aspect of stone disease management. And we close with a full reference list for your readings. Let us get started with slide number 1. Let us begin with the burden of this condition. Ureteric stone disease is remarkably common. The lifetime risk of developing urolithiasis, that is any stone in the urinary tract, is approximately 10 to 15% in the general population. This means roughly 1 in 7 people will experience a stone at some point in their life. What makes this condition even more significant is its recurrent rate. Without intervention or prevention, approximately 40% of patients will have a recurrence within 5 years. This underscores the importance of the preventive measure, and we will discuss later. This is a well-established male predominance. Men are twice as likely as women to develop stones, although the gap is narrowing, particularly in postmenopausal women. In terms of stone composition, calcium oxalate is by far the most common type, accounting for 70 to 80% of all stone. This is followed by calcium phosphate, uric acid, steroid, also known as infectious or triple phosphate stones, and the rare cystine stones. On the right, you can see the risk factors, which is dehydration and low fluid intake are the most modifiable risk factors. Dietary factors, particularly high oxalate, sodium, and animal protein intake, play a significant role. Medical conditions such as hyperparathyroidism, gout, and renal tubular acidosis predisposed to stone formation. Structural abnormalities like ureteropelvic junction obstruction or harsh kidney impaired urinary drainage. Now, positive family history doubles the risk. Understanding these factors is fundamental to both counseling patient and preventing recurrence. Now let us look at the anatomy because understanding where stones get stuck is essential for management decision. You can see the renal tract illustrated here with the kidneys above, the ureter bilaterally, and the bladder at the base. The ureter is conventionally divided into three segments: the proximal ureter, the mid ureter, and the distal ureter. The proximal ureter running from the ureteropelvic junction down to the superior border of the sacrum, the mid ureter crossing the iliac vessel over the pelvic brim and the distal ureter from the iliac vessel down to the ureterovesical junction. This is where the majority of stones are found, the VUJ. There are three critical nerve points at the ureter where stones are most likely to impact. The first is the pelvic junction, which is the narrowest point in the entire ureter at just 2 to 3 millimeters. This is the most common site of stone infection. The second is at the level of the iliac vessel crossing, where the ureter passes over the pelvic brim. And the third and the most clinically significant is VUJ, where the ureter enters the bladder. Interestingly, approximately 70% of stones that spontaneously pass do so at this location. At the bottom of the slide, you can see a critical summary of stone passage. Stone passage rates by size. Stones smaller than 5 cm pass spontaneously in about 68% of cases. Stone between 5 and 10 mm passes in about 47%, and stone larger than 10 mm almost universally require intervention. These figures directly guide our management algorithm. Now let us discuss how we classify and grade ureteric stones. This is central to making management decisions. Starting top left, classification by stone size. Small stones less than 5 millimeter. These have a high spontaneous passage rate of around 68% and are managed conservatively with medical expulsive therapy. Medium stone, which is 5 to 10% mm, have a moderate passage rate in a trial of medical management is acceptable, though intervention may be needed. Large stone greater than 10 mm have a very low chances of spontaneous passage and typically require procedural intervention. On the top right, classification is based on the location. Uh, Proximal ureteric from the pelvic ureteric junction to the upper border of the sacrum, mid-ureteric across the sacrum, and distal ureteric, which is from the lower sacrum to the VUJ, which is the most common location, pastoral infection. In the bottom left obstruction grading using the SFU grading system endorsed by the EUA guidelines, in which grade 0 is no hydronephrosis, grade 1 is mild, only the renal pelvis is dilated, grade 2 moderate, in which both pelvis and calyces are dilated, grade 3 and 4 severe with thinning of renal parenchyma, which indicates long-standing obstruction and risk of permanent renal damage. In the bottom right, there is classification on the basis of radiological opacity, which is an important consideration. The stones are radiopaque, which is visible on plain KUB. Extra QB include calcium oxalate, calcium phosphate, and steroids, and the radiodistant stones, which is uric acid, cysteine, and xanthine. These are invisible on extra QB and require CT for detection. This classification framework directly informs our imaging choice, management strategy, and urgency of intervention. Moving now toward the clinical presentation and how we evaluate this patient. Clinically, a patient with acute ureteric stone typically presents with severe colicky flank pain radiating from the loin to the groin. The classical ureteric colic. The pain is typically excruciating and comes in waves. Patients are usually restless and cannot find a comfortable position. This helps distinguish it from peritonitis, where patient is lie still. Associated symptoms include nausea, vomiting, hematuria, with hematuria is present in about 90% of cases, and parodistal stones, lower urinary symptoms such as dysuria and frequency. Critically, fever and rigors and the presence of ureteric stones should be treated as a urological emergency. This pattern suggested an infected obstructed kidney, uh, which is pyenobrosis, and it requires immediate decompression. For investigation, urinalysis is the first step. Look for hematuria, pH, and crystals. Blood should include blood investigation include CBC, renal function, CRP, and serum calcium and uric acid. Urine culture is essential recurrent stone if infection is suspected, and recurrent stone forms a 24-hour urine collection for metabolic work is invaluable. The imaging table at the bottom summarize our modalities, which is the first one is non-contrastive QEB, and it is the gold standard with sensitivity and specificity both exceeding 96 to 98%. It provides stone size, density, and hospital unit, skin to stone diameter, all critical um, requirements for treatment planning. Ultrasound is preferred in pregnancy and pediatric age. It avoids radiation and reliably detects hydronephrosis, though it has limited sensitivity for the stone itself. Plain KUV has modest sensitivity and is mainly used for monitoring non-radiopaque stones. And IVU has largely been replaced by CT in most centers. Remember, for any patient with suspected infected obstruction, imaging must not delay intervention. Now, let us turn to the management, beginning with conservative and medical approaches. Not all uteric stones require immediate surgery. The EAU guidelines support a trial of conservative management in selected patients. The criteria for observation are stone size less than 10 mm or equal to 10 mm, ideally less than 5 mm, controlled pain, no signs of infections, uh, normal or near normal renal functions, and no high risk anatomical features such as solitary kidney. The cornerstone of medical management is medical expulsive therapy or MET. The first line agent is tamsulosin, an alpha 1 receptor blocker at a dose of 0.4 mg once daily. It works by relaxing the smooth muscle of the distal ureter, facilitating stone passage. The evidence is strongest for distal ureteric stones, 10 mm or less, where it significantly increases passage rate and reduce time to passage. And as we know that alpha receptors are mostly present in distal ureter and then distally. The second option is nifedipine, a calcium channel blocker. It is an alternative, though the evidence is less robust than the that part of psilocybins. Corticosteroids have been used as adjuncts to reduce ureteric edema and inflammation around the stone. Um, for analgesia, NSAIDs such as diclofenac or ketorolac are the first-line choice. They not only provide superior analgesia compared to opioids in many studies, but also reduce uterus spasm and prostaglandin-mediated inflammation. Paracetamol is useful as adjunct opioids are reserved for um, rescue analgesia. Regarding IV fluid, adequate hydration is important, but post-diuresis is not recommended as it increases intra-urethral pressure without improving stone passage. The duration of watchful waiting should not exceed 4 weeks as per EAU guidelines. During this period, patients should strain their urine to capture the stone for analysis. Imaging should be repeated if pain worsens or if there is clinical concerns. Prompt escalation to intervention is required if the patient develops fever, worsening renal function, or there is no passage after 4 weeks. Now let us discuss the surgical options, when and how we intervene. First, the absolute indication for intervention. These are situations where conservative management is not appropriate and intervention must happen, sometimes urgently. Uh, the first one is an infected obstructed kidney pyelonephrosis. It is a true urological emergency. Uh, the sepsis secondary to an obstructed infected urine is life-threatening and requires immediate decompression. Acute kidney injury or renal failure. bilateral obstructed stones, a solitary kidney with obstruction, and intractable pain or vomiting despite maximal analgesia are all absolute indication. Stones greater than 10 are a relative indication. Now, the three main surgical modalities are ESWL, which is shockwave lithotripsy, URS, and PCNL. Now going toward shockwave lithotripsy, this is non-invasive procedure using external shock waves to fragment stones. It is the first line, chest proximal ureteric stone less than 10 Success rates are 70 to 90% per smaller stone. It requires 2000 to 3000 shocks per session and may require repeat treatments. It is contraindicated in pregnancy, coagulopathy, and abdominal aortic aneurysm. Uh, the second one is ureteroscopy with laser lithotripsy. This is the workhorse of modern stone surgeries. Simulated or flexible ureteroscopes are passed up the ureter under direct vision. The Holmium Yag laser is used to pigment the stones. It is highly effective and safe. Success rate exceeds 90%. And a double J stent is typically placed post-procedural for a few weeks. URS is first line for most distal and mid-ureteric stones greater than 5 then the last one is PCNL, percutaneous nephrolethotomy. This is reserved for large proximal stones greater than 15 to 20 and impacted UPJ stones that have failed other treatment. It involves placing a nephroscope directly into the kidney through a percutaneous tract. It has the highest stone-free rate for large stones. Mini and micro PCNL variants have reduced complication rates. Per-operative antibiotics are mandatory. Pre-operative antibiotics are mandatory. Um, and bottom uterine access sheets are now a note at the bottom which shows a uterine access sheet are now routinely used with flexible URS to improve visibility and reduce intrarenal pressure during the procedure. Now towards management algorithm or critical decision framework for acute uteric stones aligned with EAU 2024 guidelines. When a patient presents with an acute ureteric stone, the very first question we ask is the patient kidney is infected? Is there acute kidney injury or is there a solitary kidney? If the answer to any of these is yes, then this is an emergency. We do not wait. We proceed immediately to decompression. This can be achieved either by retrograde insertion of adjacent uterine stent under a cystoscopic guidance or by percutaneous nephrostomy under ultrasound guidance. The choice depends on the local expertise and the clinical situation. Definitive stone treatment follows once the patient is stabilized. If the patient does not have any of these high-risk features, we then assess stone size and location to further to guide further management. Small stones less than 5 mm, particularly in the distal ureter, are managed with medical expulsive therapy, temsulocin, and adequate analgesia. We observe for up to 4 weeks. Medium stones 5 to 10 we can either try MET or proceed directly to early intervention with URS or ESWL, depending on the patient preference, stone location, and symptoms burden. Large stone greater than 10 especially proximal, require active intervention. URS or ESWL for most proximal stones. We reserve PCNL and mm, PCNL are reserved for stones greater than 15 to 20 proximal ureteric stones. This algorithm ensures we do not miss emergencies while avoiding poor treatment of stones that will pass spontaneously. Now, some special clinical scenario that deserves particular attention. The first one is urethritis in pregnancy. It requires special consideration. Radiation must be minimized, so ultrasound is the first line imaging modality. MRI without gadolinium is an excellent option if ultrasound is inconclusive. Conservative management with analgesia, avoiding acid is the third trimester is preferred as many stone pass spontaneously. If my intervention is absolutely necessary, ureteroscopy is the safest surgical option throughout pregnancy. ESWL is absolutely contraindicated in pregnancy. Now, toward the pediatrics, in children, ultrasound is the preferred imaging modality due to radiation sensitivity. A metabolic evaluation is mandatory in all pediatric stone farmers to identify the underlying metabolic disorders. ESWL is effective but require careful consideration given the developing kidney. Mini URS and mini PCNL are increasingly used in children with good outcomes. Now, towards the salivary kidney, an obstructed kidney, the stones in a patient with salivary kidney, whether anatomical or functional, is a urological emergency. Even a partially obstructing stone can cause acute kidney injury. Immediate decompression with adjacent or nephrostomy is required, followed by definitive treatment once stable. This patient required very close follow-up. Staghorn stone and large calliculi. Parstek-Hahn calliculi stone, uh, Parstek-Hahn calliculi stones that occupy the renal pelvis and extend into the multiple calyces. PCNL treatment of choice. Stone pre-rates with PCNL are significantly superior to ESWL per stone greater than 15 mm. That procedure may be needed for very large stone burden. The operative urine culture and antibiotic cause are mandatory given the risk of sepsis. And follow-up of the stone treatment is important as the treatment itself, and this is an area where we can make a real difference in preventing recurrence. Imaging follow-up after any intervention, we arrange ultrasound of the kidney, ureter, and bladder at 4 to 6 weeks to confirm stones clearance and resolution of the hydronephrosis. If residual fragments are suspected, particularly after ESWL, a non-contrast CT provides definitive confirmation. Any digestions plus the time of URS should be removed at 4 to 6 weeks postoperatively to prevent infestation and stunt-related complication. Asymptomatic residual fragments smaller than 4 mm can be monitored with annual ultrasound. Now going toward the metabolic evaluation, it is for recurrent stone farmers. A detailed metabolic evaluation is essential. This include 24-hour urine collection, measuring oxalate, citrate, uric acid, and calcium. Serum investigation should include serum calcium, phosphate, uric acid, parathyroid hormone, and renal functions. Urine pH is particular and permittive. Persistently acidic urine pass to uric acid stones, and persistently alkaline urine with recurrent infection suggest steroid. Uh, our stone retrieved should be sent for analysis using infrared spectroscopy or X-ray diffraction. Lifestyle and dietary advice. These include fluid intake of at least 2.5 liters per day. Targeting a urine output of 2 liters per day is the single most effective intervention to prevent recurrence. Reducing sodium and animal protein reduce urine calcium and uric acid excretion. Dietary calcium should be kept normal, around 800 to 1200 milligram per day, as restricting calcium paradoxically increase oxalate absorption. Foods rich in oxalate, such as spinach, nuts, chocolate, and tea, should be moderated in calcium oxalate stone farmers. And the pharmacological and preventions, diuretics reduce urinary calcium and are used for hypercalciuric stone farmer. Potassium citrate alkalinizes the urine and increased citrate used for hypocalcemia citriuric and uric acid stone formers. Pyranol reduce uric acid production and is used in hyperuricosuric patients for cystinuria, deep in salamine, uh, or Tiopronin can reduce cystine crystallization. Long-term antibiotics and urease inhibitors may be needed to avoid stone recurrence. The six key TQB notes for today's presentation is one. The first one is non-contrast CTQB is the gold standard imaging modality by Ureteric stone with sensitivity and specificity of 96 to 98%. It also gives us critical information about stone size, density, and skin to stone distance, all of which guide treatment planning. The number two is small stone less than 5 mm can be managed conservatively with medical expulsive therapy, primary alpha blockers such as tamsulosin, and appropriate analgesia with observation for up to 4 weeks. The third one is an infected obstruction kidney is a true urological emergency. Fever plus obstruction means we decompress immediately. No delay for further imaging or conservative measures. The fourth one is ureteroscopy with laser lithotripsy is the first line surgical option for most distal and mid-ureteric stones greater than 5 mm. ESWL is preferred for proximal stone less than 10 mm and suitable candidates. The fifth one is PCNL. For PCNL achieves the highest stone-free rates for large proximal stones greater than 15 to 20 mm and remains the treatment of choice for sterile horn folliculi. And the sixth one is stone diseases as a recurrent condition. Adequate hydration, diet modification, metabolic evaluation, and target pharmacotherapy are essential to reduce the 40% 5-year recurrence rate. These 6 points encapsulate the core of evidence-based stone management. The content of presentation has been drawn from the following references, most probably from the EU guidelines and the Campbell. And with that, we reach the end of our presentation. I want to sincerely thank you all for your time, attention, and engagement throughout this talk.